Good morning. I'm Dr. Susan Dubois, and I'm here at the University of Texas School of Nursing Family Wellness Center to talk to you today about the comprehensive diabetic foot exam. Our resource for this discussion are the 2014 guidelines from the American Diabetes Association, and you can find a more comprehensive version about the diabetic foot examination in this document, a report of the task force of the Foot Care Interest Group of the American Diabetes Association and the American Association of Clinical Endocrinologists. This came out in Diabetes Care in 2008. All right, let's talk about why we're doing this examination. We're examining the diabetic foot for two reasons. One, to identify high-risk feet, so that two, we can act upon that and prevent a diabetic foot ulcer. Diabetic foot ulcers are important. About 1 in 6 of every patient with diabetes will get a foot ulcer during their lifetime. About 1 in 5 hospitalizations for diabetes are due to diabetic foot ulcers, and 2 to 5% of those ulcers lead to amputations. So it's really important that we identify high-risk feet and then educate and provide treatment for patients to prevent ulcers. Well, let's get started. What equipment do we need? We need the 10-gram monofilament. We use this disposable one here at Family Wellness. If you're using a reusable filament, just make sure that you've properly cleaned it with an appropriate disinfectant. We also need the 128 Hertz tuning fork, and I'll show you why in just a minute. We need good lighting, so you might want to turn on a lamp. And we also need a comfortable place for the patient to put up their feet so that you can see them. Don't forget to have some gloves nearby. I don't always use these, but if a patient has an open wound or if their feet are obviously dirty, then you're going to want to use a glove. All right, so we start by just looking at the feet. We're looking for any cracks or fissures. We're looking for any deformities that could rub on the shoe and cause an ulcer. This could be a bunion, it could be a hammer toe, anything like that. If we notice anything like that, we want to educate the patient while we're doing the exam. So we might want to say something like, you need to take care of the skin on your feet to prevent you from getting any kind of dry cracks or anything. Then we're also going to start by examining the pulses. So we have 4 pulses, one on the back of each foot. This is called the dorsal pedal, and we're just going to feel it. We have a nice pulse there. We're also going to feel the posterior tibial pulse, which is right behind the ankle bone on the inside of the foot. And we have a good pulse there. We're going to feel the dorsal pedal here and the posterior tibial here. In the normal exam, you should be able to feel all the pulses. This takes a little bit of practice, so if you're new to doing a foot exam and you don't feel the pulses right away, think about it in context. Does it make sense that this person has vascular disease? If they're young, healthy, newly diagnosed diabetic, they probably have normal pulses, so you just need to continue till you learn how to do that. Also, we can look at the skin of the feet. If it's shiny, hairless, if there's no hair on the toes, that might indicate a patient who has vascular disease. All right, I'm going to demonstrate now how to do the monofilament exam. Now what you're going to do is you're going to touch the toes lightly, and I like to do the 1st, 3rd, 5th, 2 places here and 1 there. And you're going to want to not put it right on a callus because they might not feel it there. You'll say something like, I'm going to touch your feet. If you feel anything, let me know. And if they don't immediately feel it, you might try touching their hand so that they have a reference point for what it's going to feel like. Okay, please say yes every time you feel the touch.
Yes, 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 yes.
And you'll notice when I do it, I make the tine depress a little bit, bend a little bit. Hold it for a second and come out.
Yes, 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 yes.
And you'll notice I vary the speed a little bit so the patient's not just saying yes, 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 and I know that they really do feel it. They should have their eyes closed during that part of the exam. The next thing we're going to do is the tuning fork. Strike it so that you hear a clang, and then place it right here on the joint below the big toe and say, please tell me when the vibration stops. And actually you make sure they feel the vibration first. Did you feel the vibration?
Yes.
Okay, tell me when it stops.
Now.
Okay, a normal examination is 12 seconds or longer, and you'll just notice young people sometimes feel at 15 or 20 seconds, older folks might be 12 or 15. Okay, you should have a clock in the room. This nice clock, actually, I can hear the second hand, or I can count in my head, 1, 1,000, 2, 1,000, but
I feel that. Okay.
okay, that's a perfectly normal examination. Okay, if you don't have a tuning fork, you can do ankle jerks with this, but they're not quite as consistent in examination, so we prefer the 128 gram tuning fork. If I was doing ankle jerks though, I would ask the patient to relax their legs, and I would gently hold the foot up and strike the ankle, and we can see a slight movement as the reflex occurs. So that is an acceptable fourth component of the exam. So again, the comprehensive diabetic foot exam is 4 components. The first is inspection and looking for deformities that can rub on the shoe and cause an ulcer. The second is palpating the pulses, dorsal pedal and posterior tibial of both feet, to check for circulation. The third is looking for protective sensation, and we do that with the 10 gram monofilament. And the fourth is checking for vibratory sensation with the tuning fork. We can substitute ankle jerks if we don't have a tuning fork. So a high-risk foot has the triad of all 3 problems. They have a deformity that can rub on their shoe and lead to an ulcer. They have poor circulation, and they have loss of protective sensation. If they have all 3 of those, they definitely must have some diabetic shoes. Usually those are custom made to protect their feet, and they should have good education about inspecting their feet daily and so forth, and what kind of creams might be appropriate to keep the skin soft and to avoid callus formation. If they have loss of any one of those things, they still have feet that are at moderately increased risk, and so we want to talk to them about education. So once again, the purpose of this is to identify high-risk feet so that we can then do some actions such as get the patient appropriate footwear or refer them on to a podiatrist or specialist for nail care or other things that might prevent problems in the future.